Next question. A 31-year-old woman comes to the office for a reevaluation. 2 weeks ago, she came to the office because of depressed mood, poor sleep, poor concentration, and diminished appetite. She was subsequently started on fluoxetine. She now says that she does not feel her symptoms are improving and asks for another medication to treat her depression. Which of the following is the most appropriate next step in management? A. Increase the dose of fluoxetine. B. Reassure the patient and follow up in 4 weeks. C. Stop the fluoxetine and start another SSRI. Or D. Stop the fluoxetine and start duloxetine. The correct answer for this is reassure the patient and follow up in 4 weeks. Remember that this patient has not had an adequate trial on the fluoxetine. Antidepressants can take 4 to 6 weeks to take full effect. Specifically, we're talking about the SSRIs. The first line of treatment for depression is an SSRI, so you gave her the right medication. These drugs may take up to 2 weeks to have an effect and up to 6 weeks to obtain an optimal effect. SSRI dosage or regime is generally not changed until one agent is given for at least 6 to 8 weeks. Now, if an individual does not respond to one specific SSRI, switching or staying in the same class are both reasonable options for the second medication. Next question. A 52-year-old man comes to the office because of bouts of tachycardia accompanied by a sense of impending doom for 7 months. He has been concerned about these unpredictable attacks for the last 2 months and that he cannot think of anything that could have started them. These episodes began as palpitations and progressed to pounding tachycardia. They are accompanied by cold sweats, tremor, dizziness, and the feeling that he's going to die. Serum catecholamines and cardiac enzymes are within normal limits, and his heart rate and blood pressure is fine. A week-long trial on a Holter monitor even showed no signs of arrhythmia. The patient works as a full-time yoga instructor and lives with his wife and young child. Which of the following is the most likely diagnosis? A. Acute stress disorder. B. Generalized anxiety disorder. C. Panic disorder. Or D. Specific phobia. The correct answer is C, panic disorder. And why is that? Well, panic disorder is characterized by recurrent, spontaneous panic attacks without an obvious cause or trigger, with at least 1 month of persisting fear of experiencing another attack or significant behavioral changes related to the attack. A physical cause of the symptoms must be ruled out before establishing a diagnosis of panic disorder. Remember, we would want to be thinking about thyroid disease and cardiac disease, which is why this patient already had a workup with a Holter monitor. The DSM-5 criteria for panic disorder are panic attacks associated with longer than 1 month of subsequent persistent worry about having another attack or consequences of the attack, or significant maladaptive behavioral changes related to the attack. The panic attacks are defined as a period of intense fear in which symptoms develop abruptly and peak rapidly in less than 10 minutes from the symptom onset. Generalized anxiety disorder can be tricky. You might have thought it was that, but that is characterized by excessive anxiety and worry occurring most days of the week, lasting longer than 6 months, and an inability to control the feelings of worry or anxiety in at least 3 of the following: restlessness, fatigue, trouble concentrating, irritability, muscle tension, or sleep problems. All of these symptoms must cause distress and interfere with functioning. Remember, as far as panic disorder versus GAD, panic attacks can occur in generalized anxiety disorder, GAD, arising out of escalating and uncontrollable worry, but the presence of unexpected or uncued panic attacks is unusual in GAD. Patients with panic disorder tend to have episodic and calamitous thoughts about presumed life-threatening acute illnesses, whereas patients with generalized anxiety disorder focus more persistently on less specific but more chronic complaints involving multiple organ systems. Next question. A 14-year-old girl comes to the clinic because of increasingly odd behavior for the past year. She's accompanied by her adoptive mother, who states that sometimes the child has episodes in which she will not answer to her name. Her name is Anna, but episodically she speaks in an accent, calls herself Cleo, and acts completely differently. Patient denies this, but does report brief lapses in her memory. Her grades in school have suffered over this time, and she no longer has friends. She displayed similar behavior when younger, but it seemed age-appropriate at the time. Her medical history includes physical and sexual abuse at 5 years old. Vital signs and physical examination are non-contributory. She denies auditory or visual hallucinations. Complete metabolic panel and urine drug screen show no abnormalities. Which of the following is the most likely diagnosis? A. Dissociative identity disorder. B. Manic episode. C. Narcissistic personality disorder. Or D. Schizophrenia. So, dissociative identity disorder is the correct answer. Remember, DID, or dissociative identity disorder, previously known as multiple personality disorder, is a mental condition characterized by the development of at least two distinct personality states that alternately dominate a person's behavior. Patients have extensive lapses in memory of important information. It typically occurs in victims of significant childhood or chronic trauma, like this patient's sexual trauma, and schizophrenia may present with delusions and hallucinations. However, these are going to be different than this patient, in that they are more likely to be chronic and not involve these episodes of loss of memory. Remember, dissociative identity disorder is best treated with psychotherapy in an effort to integrate the identities, discuss the difficult memories, and promote safety. If you're looking for this as a diagnosis on a board's question, you're going to need some of these lapses in memory, as the patient really is not supposed to remember the periods when they have the other personality when they're talking to you in their first personality. So, as these patients often have comorbid PTSD and depression, selective serotonin reuptake inhibitors should also be considered. This condition is also associated with a history of sexual abuse, substance abuse, somatoform conditions, and borderline personality disorder. Next question. A 23-year-old woman comes to the psychiatric outpatient clinic because of a tremor for the past 2 weeks. Her past medical history is significant for bipolar I disorder, recently started on maintenance therapy with lithium 2 weeks ago. She reports that she developed the tremors ever since starting lithium. After discontinuing the lithium, which of the following is the next best step in management? And the answer choices are A, buspirone, B, electrical convulsive therapy, C, quetiapine, or D, sertraline. And the correct answer is C, quetiapine. Remember that quetiapine, the brand name is Seroquel, so you'll hear that a lot, but we do not do brand names on this podcast, and you do not need to know brand names for the boards, but just so you have that association, is one of our antipsychotic medications associated with a lot of weight gain and is definitely a second-generation antipsychotic, but it's one of the ones that is the best for treating an acute manic episode. And actually, maintenance therapy with quetiapine is indicated for stabilizing the mood associated with acute mania and preventing manic episodes in patients with type 1 bipolar. Lithium, probably we hear about that even more frequently, is another very good one. And divalproex or valproate is also a good treatment for bipolar I disorder to prevent recurrence of manic symptoms. Next question. A 9-year-old boy comes to the office due to concern over his repeated difficulties in school. His mother explains that over the past 6 months, she has repeatedly met with his teacher due to his conduct. His teacher said that he constantly speaks loudly without raising his hand, does not clean up his assigned area, and does not finish his homework on time. During the office visit, the patient is constantly grabbing objects and is very irritable. Which of the following is the mechanism of action for the drug most commonly used to treat this condition? A, blocks reuptake of dopamine and norepinephrine. B, cholinesterase inhibitor. C, D2 receptor antagonist. Or D, 5-HT2 receptor antagonist. And the correct answer is A. Methylphenidate or Ritalin is a stimulant agent that works by inhibiting the reuptake of dopamine and norepinephrine and is used in the first-line treatment of attention deficit hyperactive disorder. Remember that a child with ADHD will present with limited attention span, poor impulse control. Some of the signs of inattention include trouble holding attention, failing to finish schoolwork or duties in the workplace, trouble organizing tasks, being easily distracted, and often forgetful in daily activities. Some signs of hyperactivity and impulsivity can include not being able to stay seated, often fidgeting or tapping their hands or feet, often on the go, talking excessively, and often having trouble waiting. Remember the timeline. This is psychiatry. These symptoms of inattention and hyperactivity or impulsivity must be present for at least, here it is, 6 months, present before the age of 12, and are present in 2 or more settings. Methylphenidate is a stimulant medication that works by inhibiting the reuptake of dopamine and norepinephrine. It is the first-line treatment for ADHD. Common side effects include appetite suppression, so you have to watch, make sure they don't lose too much weight, abdominal pain, headache, and insomnia. CBT, cognitive behavioral therapy, is also considered an effective adjunctive therapy for ADHD, except you should know that the overwhelming evidence is that the pharmacotherapy is by far more effective if you are going to have just one of them. You may have thought cholinesterase inhibitors, however, those are used to treat myasthenia gravis and glaucoma, so that would not be the correct answer for a patient presented with one of these ADHD type presentations. Again, the timeline is must be present for at least 6 months as far as the symptoms, present before the age of 12, and in 2 or more settings, which is why we send kids home with a survey that is to be completed about their symptoms by both the teachers at school and the parents at home, looking for 2 or more settings to demonstrate the symptoms. Next question. A 4-year-old girl comes to the office because she has suddenly stopped talking. She has a roughly 20-word vocabulary at her last visit 1 month ago, but has not talked in 2 days. Her parents say she has become less socially engaged since the last visit, but they thought she was just shy. Physical examination shows an unsteady gait, and throughout the exam, she sat quietly in the corner, wringing her hands together. She has bruises on her knees, which her parents say happened after falls. Which of the following is the most likely diagnosis? A. Autism spectrum disorder, B. Child abuse, C. Failure to thrive, or D. Rett syndrome. The correct answer is D. Rett syndrome. Unfortunately, Rett syndrome is a rare X-linked genetic postnatal disorder of gray matter and is characterized by early normal growth and development, followed by a loss of milestones. It does affect girls exclusively because males die in utero. Clinical features include small hands and feet and a decreased rate of head growth. Child abuse would be suspected in a child presenting with repeated injuries that are inconsistent with the story about how these injuries occurred. Bruises on the knees after saying that the kid fell kind of does make sense. Bruises on inner thighs or abdomen, places that would be normally hidden or unlikely to be injured in routine falls, that would be more suspicious for child abuse. X-rays showing fractures at different stages of healing is also strongly suggestive of child abuse. Next question. A 2-year-old boy comes to the pediatric clinic because of poor language and social skills. He was given up for adoption at birth and adopted at the age of 12 months from a Romanian orphanage. His parents say he is withdrawn, fearful, and suffers from recurrent bouts of minor illness. They take him and his 2 siblings to the park every week, and he tends to sit on benches alone. Physical examination shows poor muscle tone. He is at the 15th percentile for weight, 30th for height, and minimally responsive to physical and social stimuli. Which of the following is the most likely diagnosis? A. Disinhibited social engagement disorder, B. Reactive attachment disorder, C. Rett disorder, or D. Separation anxiety disorder. And the correct answer is B. Reactive attachment disorder. Anaclitic depression is a pattern of wasting and psychological depression thought to stem from lack of social contact during key child developmental periods. This symptom is in addition to the history of living in an orphanage for the first year of life, is consistent with the diagnosis of reactive attachment disorder. Remember, this kid during his first year of life did not form good bonds with parental figures. Symptoms include a lack of social reciprocity, limited expressions of joy, and failure to seek comfort even when distressed. Poor physical growth is also seen in severe cases. This constellation of symptoms can be seen with child abuse, so careful consideration and investigation is paramount. Treatment should focus on establishing a stable, nurturing environment, and parent education and psychological counseling can assist in doing so.